All right. Thanks, everybody, for coming to join us today. I understand we're competing against sim wars right now, which is just not fair, but that's okay. So we are here as one of the abstracts sponsored by the Faculty Development Committee and talking about how to jumpstart or restart a faculty development program. I'll have everyone introduce ourselves. This is more of a discussion than necessarily a didactic session. I'm Liz Berner from University of Southern California and currently Director of Faculty Development there.
I'm Deb Diercks. I'm Chair of Emergency Medicine at UT Southwestern in Dallas.
I'm Sanjey Gupta. I'm Chair of Emergency Medicine at South Shore University Hospital, part of Northwell Health, part of Sucker School of Medicine.
Hi, Penny Lema, Vice Chair of Faculty Affairs at Columbia University, New York.
So we're hoping today that after our session, you all have the plans for putting together a needs assessment and start your faculty development program. I identify various areas of faculty development to emphasize and plan for strategies such as didactics, peer coaching, and workshops. So I think we wanted to start with just a discussion of what is faculty development, and I feel like this might turn into a 45-minute session on its own. But there's a lot of different areas that now are part of faculty development. I think kind of a traditional version of it is how to build academically productive faculty members. But that has changed, especially in the last 3 or 4 years. And I wanted to get everyone's opinions on what are the areas that you think about in faculty development.
Yeah, that's a tough one, right? I think the challenge with faculty development, and it means something different to each individual faculty member. And so I think when I think of faculty development, I try to ask the individual what they want to be developed in. And where you are has a big impact. So we're not in an up or out institution. When I was at UC Davis, you went up for a merit every 2 years, had to go up for promotion. Well, you don't have to be promoted at UT Southwestern. You could be a terminal assistant professor for the rest of your life. And so for those people that have no interest in getting promoted, their faculty development looks so different than somebody who wants to, right? It's still important because if you don't focus on developing them, they may not feel valued. And that isn't the message you want to send to any faculty member, that they aren't important and that their contributions aren't appreciated. And so development's going to differ based on the goals of the faculty member, your institution, what you have to do, and recognizing that development is an individual sport is part of the challenge of when you set up a program.
Yep, and I will touch upon that and agree. I've always, in my career, worked in residency programs that are not necessarily directly university-based. So you have clinical departments that teach, if that makes sense. And you have a lot of these around New York City, where I've always trained. So then it almost takes a secondary effect where you have a lot of people who want to work with residents, who want to teach at the bedside, but the concept of developing that individual kind of academic development for their career is going to be very different. For the large part, it's many people who want no part of it, if that makes sense. And for the folks that do, it's that individual plan becomes very important. So a sustainability of that plan, but also getting the resources for that, because the concept of about to go down the rabbit hole of like protected time for this development may not be as meaningful to a place where the return of investment is actually your clinical billing versus anything else. So it turns into a different challenge at many of these sites. So I always like to come and speak to represent these sort of programs and talk about how that sort of, the pathways in those programs are very, very much different.
I agree. Everybody should have an assessment of the stakeholders. What do you want out of it? So we have our own faculty put their own individualized annual plans together with the chair and vice chairs. And then for our faculty development committee, we come up with a needs assessment and separate it into different categories of which of these lectures or workshops would you want in under clinical, under education, research, under your professional development skill set, or your personal growth. And I think professionalism and also your personal growth have also expanded over the last 3 years, as well as promotions. catering to your fellows and junior faculty, mid-career and late career, and then other subgroups?
Yeah, so we do an individual development plan, and it's one I think I copied from some website when I just searched individual development. And one of the things that's interesting about it is it has the individual faculty state their mission and their vision for their career. And it happens when people get hired on. And people are like, I don't know what that looks like. I guess I teared nicely into yours. Good tee up. But just really kind of having people really focus and identify what they value. Because I think it's hard when you start a job, you're like, I just want to be great, right? You know, but having to really think about what you want to do is important and it helps, right? Because otherwise we don't know what to do.
Individuals' mission and value goals.
Yep.
Love that.
Yeah, so this was an area for us to discuss, was the idea of individual development plans, because I think they mean different things at different institutions. So at my institution, an individual development plan is really a roadmap to becoming an independently funded investigator, and it's supported by the university. You get external members on your evaluation committee of how you're progressing on it. And for a lot of our faculty members, that is not what they're interested in. And so for them, an individual development plan in that context doesn't make sense. But I think you're talking about ways to make that fit the needs of your different faculty members.
Yep. Yeah, so ours is basically, what's your vision? What's your vision? What are you doing now? What do you not want to be doing in the future? And what are your 5-year goals? And again, it isn't focused on a researcher or anything. It's that individual, when you come in, you've been here 6 months, when you sit down with kind of, our vice chair of kind of faculty affairs, what do you want to tell them that you want to accomplish? And it just starts a really good dialogue because it helps everyone figure out what that individual's priorities are.
So I think if you thought about, the individual development plan that I think is kind of the NIH style, is like, you have a 3-member committee that's evaluating your progress and addressing areas of maybe not meeting your goals, and then they have a mitigation board to help you overcome barriers. And that's kind of more of an infrastructure than a lot of faculty members need. But using the same structure with maybe less stick and more carrot.
Yeah, absolutely. I don't think there needs, we don't have any stick in ours. We send people theirs, after a couple of years to say, hey, here's where you are. Come meet with us if you want. But this is what you said a few years ago, just to remind you. And just look at it, because people forget what they thought.
Yeah, I think for the sort of department where I am, where this is repeated in many places, is the concept of promotions is very esoteric, and I don't think it's actually on a lot of attendings' minds at all. The concept of going to an associate professor doesn't impact, any sort of tenure, because we don't have a tenure process. It does not impact employment, doesn't impact benefits, doesn't impact pay. So kind of those like tangible things that where promotions might make sense, doesn't necessarily make sense to us. So I really focus more on making sure that people actually find a niche, because that niche is going to be sustainable, and it gives them a basis, a seed to grow. So this is if someone is interested in teaching, which I know that's kind of the classic chair, what would you like to do? Oh, I'd love to teach. But what does that really look like, and what does that mean? And in what direction does that go? Or is this, I'm interested in international, I'm interested in undergraduate medical education. So we're going to take that seed and develop an individual plan like we've been talking about to grow that. But the end point for us is not necessarily, it's more based on the person and what the person wants to see out of that. And we hope that promotions comes, because we also can't assume that someone's going to stay in our hospital or our institution forever. So it allows them an ability to kind of take that promotions back at somewhere else if they need to, where those factors are impactful.
One of the challenges at larger departments, at Columbia, we're a new academic department. We're reaching our 5-year this July. And with 150 faculty and fellows, is how do you not only enable the chair to have their effective annual meetings, but develop more intimate, smaller mentorship groups outside of people's subspecialty, like ultrasound or toxicology or simulation. And so we have fall meetings, 6 months post-annual chairs meetings with the vice chairs, who have taken a cohort of mentees, which are all the faculty, and come up with their individual development plans and go over their 3 identified goals and kind of get ahead of what are your barriers to reaching that goal and timeline, and help you connect with outside networks, whether it's other societies or regional or within hospital or medical school groups, to try to achieve those goals, or other partners or writing groups or scholars within your department to help you achieve those goals before your own timeline.
I think it's just important for people to realize that not everybody wants the pinnacle of the academic career that kind of wasted out there, and kind of what you think when you started, or I started, which was the triple threat. Could you be good in teaching and clinical and research? And that was what an academician looked like. We're developing and having to work with people, who don't want that. I have a faculty member who I think they're great. They're nocturnists like me, but comes up to me and says, I don't care if I get more money for being promoted. I would rather work the 5 extra shifts that gets me a year than have to do all the research and write. And that is okay. I know where they stand, but they still want to be developed, and there's still areas that they're interested in and want to, learn about, but it's just not along that traditional promotion path.
That is a good point, because that brings out people's value for the department. Some people might just want to become better clinicians, and we have a cohort of faculty who wanted to practice some skill sets in a procedure, like airways and fiber optic scopes, without residents, without fellows, so that they can practice their skills without other learners around. So we set up development procedurals and clinical success plans for some faculty. So we integrated that into faculty meetings so that all stakeholders would be involved. Same with the DEI conversations. We implemented within the faculty time so that we can try to help provide that for DEI conversations in the workplace and in the clinical arena in faculty meetings. So it's not just those who are interested in those topics to show up.
I swear this has been an open discussion, and it just happens to follow along our slides somehow. But I think that brings up an important point. Do you encourage your faculty to stretch beyond their one, area of excellence? How have you encouraged faculty to do that, or do you let them select on their own? Or does it change?
I think it's a different role, right? I think from a chair's, even like I said, even though I have faculty who have no interest in promoting, my goal is to get everyone to be promoted, right, and to succeed. And so there's no way I'm going to tell a faculty member, even if they have no interest in scholarship, that they shouldn't do it, right? I can say, hey, can you consider it? I know we'll focus mostly on that, but let's still draw you back in a little bit. And can you think about it maybe, or can you participate maybe? So I think it's really hard to completely ignore all those things that were judged on as academic, but you just try to focus on where they have the highest likelihood of succeeding, and 2 out of 4 of these buckets is good enough if they can do it.
Absolutely. I think the era of being voluntold to do things is over, which was a different area, and that was during a very big growth time in emergency medicine. But I think now, taking into account people's personal needs, wellness needs, especially, we can all really understand what we've been through in the past few years. People's time is valuable, and what they cherish and value is very different. So, I think as faculty development directors or as chairs or faculty affairs, I think what's important for us is to kind of recognize in others, really by observation and discussion and meetings, where people can actually be valuable, but they just may not have an understanding or knowledge base about what's available out there. And these things can seem very overwhelming or daunting, but kind of using the mentoring pathway in a lot of respects, I think in my experience has been very helpful in taking more junior faculty and going, hey, I know that you really very much like this, but I do recognize that you probably actually have a lot of talent in this. Would you consider doing this? The invariable question comes back, well, what does that look like? What's the time? I need to talk to my family, or I need to do this. And I go, yeah, that's right, you do. So go do that. And when you feel comfortable with an answer, come back to me, and we'll work with you if you want to do this or not. But this is something where you can achieve. And that's often the path I take, is I think for success in a lot of ways. And we answer to a lot of people, right? We answer to builders and coders, we answer to our finance people, but we do, answer to our kind of academic folks too. And I think there's an ability to mix and match a little bit in people's various skill sets, because the one thing about emergency medicine, which is unique, and I think the faculty development conversation is unique, is that our ability to parallel process, I think, is unsurpassed in most houses, as compared to other specialties. So it's not unusual for someone to be able to be an expert in clinical care, but probably have like a really good eye for operations, and is that leader, let's say, recognized in real time during work, and can that be expanded upon? You use that as faculty development, going, hey, listen, can we put you in a leadership development program? Can we put you in this, just to also grow people for their personal sustainability in their careers? Kind of the way that the pathway that I take, and I think it's been pretty successful, especially in the types of departments that I've always worked in, which are not as heavily academically based or with that academic focus, but it seems to work and do for what they need to grow.
I think also identifying people's interests are very interesting. Sometimes it might not be obvious, especially ones who are not as communicative or verbal or extroverted. So identifying their skill strength and shining them out is one of our jobs, as well as in faculty development. We created an awards committee to try to identify different awards throughout the calendar year from different societies, and purposefully try to identify and also help people self-identify which awards they're eligible for. And so in order to do that, we had the vice chairs during their one-on-one fall meetings also identify which societies and which interest groups people are members of, so that they're eligible for certain awards. And I think try to highlight people's strengths, interests, and their wins, and to the outside world was an important part of our faculty development.
So I think when you think about faculty development, I think the challenge, the hardest thing we have, especially when you're more in a leadership position, is identifying those people who have a lot of talent but haven't been kind of developed because they don't know, or they're afraid, they don't recognize how talented they are, or they have imposter syndrome and don't want to ask, or don't want to kind of stand out, or are a little more concerned about taking that leap. And that is the group that is the hardest, because it really requires their colleagues to kind of, push them. It requires kind of at every level them, for someone to identify them. And that's really, if we're going to develop people, the people are easy that say, I am driven, I want to be developed. The harder ones are the ones that are so talented, but aren't confident or aren't internally aware of how talented they are, that really, really, really should be developed, because they are amazing. And that's where I think, even outside, that's where I think we don't need vice chairs or chairs to be. That's where we need faculty members to help and really lift up people and push people more on a granular level, because those are the people that we sometimes will miss. And that is absolutely the group we don't want to.
I think on that, how do you think these needs change throughout the course of a career? These needs for faculty development. These are like really specific content, format, intensity, timing, but I think you're talking about identification, which might be a different concept. So I guess maybe we'll start with Dr. Lema. Since we've been going this way, we'll go this way this time. How have you seen needs of faculty change throughout their career?
Definitely different in pre-pandemic was different than now. There's a lot of more personal and professional growth. People are asking for some well-being initiatives, coaching, women like having more peer mentorship, and we're having, I think that access to sponsors and mentors for our underrepresented. We identified fellows, as residence fellows, and junior faculty. I had a few exit interviews, and we found that there was a lack of mentorship for Black junior faculty, women in our department, in our hospital. There were a lot of Black women leaders, mid-career women and men, and Black men in white coats. initiative, but there were a lack of networks, so we created that. So I found that post-pandemic, there's been more needs for smaller groups and access to more sponsorship and outward networking. And so we have these peer coaching as well as mentorship groups for self-identified, underrepresented in medicine, diversity, and women, and also our LGBTQ Alliance faculty.
I think another thing that we're experiencing now, Deborah actually mentioned this, you know, there was, for a very long time in academic programs, there was almost a demand by, you know, ROC and ACGB about scholarship, right? There was a definition of core faculty, there was a definition of what the expectations were, and that varied over time. You know, 80% of your core faculty have to achieve a piece of scholarly activity every year, and those are these kind of very defined things. So there was an element of a need for a faculty development process that was probably like very formal with very specific outcomes, because if number one, you had to fulfill those needs for your department for your program to continue. But now with certain changes, I think, you know, we're experiencing a lot of changes with, you know, protected time discussion as we're dealing with other healthcare leaders about the concept of protected time for growth. But your junior faculty coming in now are also products potentially of programs where their faculty didn't really have a big demand for output or for training. So, you know, that translates. So what are you getting now? So when you talk about a format of career, I think we're actually at a really interesting crossroads right now about what that looks like for sustainability in your academic departments, what faculty development is, what core faculty are, and what their needs are for the future. So I think it's a really interesting conversation right now that you know, every department's going to be different, because it is a discussion with your medical school and with your DIOs, you know, with your service lines, and with how that could be offset and expectations. So you know, I didn't really give you an answer. I know this, it was more reflective, but when it turns into the intensity and timing, I still get the sense that people want to be developed, but what that turns into is different in terms of timing. So before, where it was hard charging and I had to be an expert in clinical work and research and teaching, now I have plenty of faculty who request to go partial FTE because of demands at home and demands with family, but they still want to be developed. They still want to go to meetings. They want to develop their niche, but might not be in the same priority or time frame that it was before. So I think as faculty development leaders, we have to take all these things into account as we are developing IDPs for people, how that really kind of reflects on your department needs as well.
I mean, I think development is, faculty development, it's a career-long effort, right? I think that what they need and what that may consist of definitely varies over the career, but I think that there is never, very few of us are happy, very few of us don't feel that development doesn't add value to ourselves, right? And make us more comfortable, competent. So I think, you know, we have people from my faculty development that run our faculty development in this room, and I believe that skill maintenance is a key important part of faculty development, right? Just because, heck, I can't remember the last time I intubated. Well, I mean, 3 years ago, but you know, it just takes a while, right? As you go on, and so, you know, as an educator, I still want to not feel like I suck at everything I do, and so, you know, that's part of the development that we've built in, because that's so important. But the things that, you know, that I need to do at my level, that, you know, are my division chiefs need, my vice chairs, and the general faculty and the junior may differ. But we've had to figure out how to do that in a different format. So how do you develop people over Zoom, right? Are there things that you need to do in person? And I think there are some things that we should be doing in person for teamwork, to actually get to know and recognize people. And I do think the intensity and the timing depends on that person's availability and what they can put in. And that's okay. It's just going to change.
And I think we touched on this a little bit, but outside of kind of, I think some of the traditional groups, atraditional, I'm not sure, however we want to think about that, groups that might need other approaches, specifically you talked about peer coaching, Dr. Lema. How do these groups need different approaches? I'll take a moment to think about that.
Yeah, no, I think right in the current state, I think a lot of them have asked me for more in-person as well as more smaller, intimate peer coaching groups. I've also aligned with the Dean of Faculty Affairs and all the resources in the hospital and the medical school and try to collaborate. So why revamp the wheel? And also there are other faculty development vice chairs in the different departments who have now shared the resources so that you're not alone. So there's a lot of collaboration within the university. And we've identified definitely there are opportunities for women in leadership and junior faculty. And then I think senior faculty you're working on is the transitions for senior faculty and those who are transitioning. And I think that we've all seen a difference in the timeline post-pandemic or peri-pandemic, that people have identified different kinds of goals professionally and personally, and retirement timelines have changed, or FTE or full-times have diminished, or their focus has changed.
Yeah, I think the biggest developments for many of these groups are the concepts that we've been talking about recently. Is mentorship is really important. And I think especially with pairing your junior faculty with somebody more senior, just as transitioning into the rigor of the clinical world, but transitioning into the responsibility of also supervising and teaching on the ground. So I think that's important, and I think with that, it's really important it gives you an opportunity to develop all facets, right? Junior faculty want to mentor, but you have to make sure that your senior faculty know how to mentor or have the skill set too. So it gives you opportunities to continue to grow people in different ways. I think it's really interesting as we talk about faculty development for clinical faculty, and we touched upon some of these things here. These are your people who probably are much more skilled in some respects than your core faculty because they just see more patients and they teach at the bedside with your residents a lot more than people who might have some. And so kind of discovering what that value base is like, so kind of the incorporation of that skill set, but especially early on, I think, is important, and to recognize that value. I mean, I've certainly worked in places where that value has not been appreciated. Really surprising because those are the folks that have the most contact time with your trainees. And I think one of the areas that we have to think about, and this has been touched on, like kind of skills maintenance, but also what do we do now with our aging workforce? People have to work, people need income, but cognitively, physically, medicine's hard work. So what happens in your end of your first decade of this work? Second decade, end of your third decade, end of your fourth, and we don't really know that yet, right? We don't have a lot of information or data on that. So that's an area of opportunity that we have, within our professional societies to look at that locally, look at that nationally. But I think that's an area that's really important, and I think the underrepresented faculty development is going to be. Is something that you don't know unless you really think about, and I think that's where kind of the concept of a broad network of mentors and developing that or discovering that is important. And the mentors don't have to be in your department. It can be in other departments. They can be in hospitals if you have a service line across multiple hospitals. The concept of thinking of now, I think the one thing about the pandemic is that we have grown our networks, right, much wider than what you have in front of you. So to try to utilize that for the sake of your faculty who need those mentors, capitalize on.
I think that's one of the challenge. Mentorship is tough to mandate, right? So, we pair, and if people start with a clinical mentor, but that can't be their mentor for their career, right? Because to really have a relationship with your mentor, you need to have trust, and you need to have some commonality of, a balance of trust and expertise to get you there. And I do think that we have really transitioned in the pandemic. The good thing that it doesn't need to be at your institution anymore. Meetings like this, finding somebody who's got expertise in an area you like, reaching out, that person can be your mentor. But forced mentorship 95% of the time does not succeed. It usually is not the relationship that gets that person to be really rewarding.
Yeah, I mean, how many senior-ish attendings here have had a medical student, a research assistant, all the above, reaching out to you going, I want you to be my mentor. You're my mentor now, and demanding it. It's going, oh, I don't have time for this, or interest, but it seems to be, I hate to say that, it might actually be just like a generational change. So that might be something to really think about, like, what do we do with that, and how do we actually take these folks who really want mentorship and find the right people.
Yeah, I think that's probably an interesting discussion too of, mentors, not a mentor, because I think that's been difficult at times for people to bridge. Like, I can't even get one mentor, let alone several mentors, but it actually is easier because you're like, I want mentorship in this one specific thing, and that's a much easier ask a lot of times, and especially if you're reaching out across institutions to someone who maybe doesn't see you every day. But there's a whole separate session on how to be a good mentee. So,
yeah, and I think this is a great opportunity for us to help our faculty develop their personal board of mentors and sponsors, their own personal connections, and help them sponsor to connect with others in the hospital and university and outside through the other networks.
we are going to skip past this a little bit because in the case study we'll talk about group size and formats, and I think we've touched on that a little bit. So we're catching up. So I think one thing is, like, there's general academic skills that we believe everybody needs. Is there anything you would add to that list that you think people just need to know this if they're going to succeed?
I think we've taken a different lens at promotions as an institution, and added a whole service track at Columbia, and that came from the Committee on Academic Promotions, and it really changed the way we looked at promotions.
So you have like a straight service track.
We have a service academy, and you could be inducted to the Academy of Service practice, and that includes social EM and some of the community outward initiatives people have participated in.
Yeah, we have something similar. I mean, we have the traditional pathways of research and education, but we do have a clinical pathway now for those devoted doctors who work for decades in your departments and watching these things grow. So there is a pathway. So I think the clinical service is certainly growing in many schools.
Our institution's about as traditional as it can be on promotion. Mostly because it's manned by 60-year-old internists, internal medicine folks that staff the entire promotion committee. So there's very little flexibility or wiggle room in that. We do have a clinical track. It's really meant for people who work in the community, not who work in the academic world. And so I think that when I think about general academic skills that everyone has to, if all of our faculty works with residents, we all need to be good educators, right? So when we focus, when the faculty decide what is part of the faculty development kind of curriculum that we have, a lot of it's focused on that, because that is kind of a uniform binding kind of alignment that transcends, all levels of promotion and all interest from researchers to clinicians to, peer educators. That is something that we are all unified around. And that is something that kind of we just hold as a core.
I think the concept of the niche is still really important. I know it's an old concept of what are you about? And so if you think about some of these traditional pathways, research, it kind of makes sense that you're going to naturally probably find a research area that is your own. But in education, I think it's really easy to dabble in a lot of different things, but when it comes down to promotions and like the educator pathway, what do you get to kind of hang your hat on? So even on that, kind of educator or other things, I think, finding a specific niche that you can make your own. So I can have a lot of people arguing with me that this is a thought process, but it makes it almost easier for you or easier for your position in your department to kind of discuss and identify when it comes to promotions. I'll give you an example, and I use this all the time. So my niche is wilderness medicine. It makes a lot of sense working in New York City, right, or around New York City. And it was very funny when I was up for promotions for professor, the feedback I got back from the committee was, we don't know what wilderness medicine is, but he seems like an expert in it. So,
Good job.
thank you. So, that's N01 or anecdotal, but at some level, it does make sense where you kind of build this whole portfolio of teaching, but it's really kind of oriented around some central themes, and those themes can certainly change over your career, but I think it makes it easier to define.
And I think, you touched on a portfolio. We decided each faculty, when they have feedback from residents and other learners, students, we try to keep it all in one portfolio so that it takes it off the faculty member, in addition to all the contributions that their updated CV and a portfolio, and awards, all that in one dossier, that when it's time for promotion, it's already on there.
That's awesome. We are going to just ask briefly, when and how do you join forces on faculty development? What have been the strategies you've used to partner with other departments, either within your institution or across institutions, or even reaching out to national committees or organizations?
Yeah, I think one of the big things that's difficult is, I'm sure with all universities and hospitals, there's probably a lot of resources that are local, and it's just kind of finding those and collating those. And this has actually been a topic of discussion with the Faculty Development Committee here at SAEM. It's how do you get this information? What's the needs assessment, and how do you get it to people? So I think it's all of the above. So formal collaborations within your department, within your institution, within your school, but then less formal as you come here, and opportunity to network and get involved with so many either your own personal pathway or to help kind of figure out those pathways that emergency physicians need. That could live here, right? That could live at SAEM. But I think this is an area that is still ill-defined, and the opportunity for growth is there. So I think the first step is probably knowing what you have at your hands. Number two is knowing what resources you may have to provide resources for your staff that may need this, and that's on the outside. But three, then also knowing what you don't know, like knowing what's the needs assessment for kind of everyone, and how do you work with your institutions like SAEM or AEM or ASAP or all the above about being able to provide those resources for its members.
I mean, I think there's resources that as leaders we know about and we have to fund, right? There's resources and there's issues the faculty know about that they want to be developed in, and they need to, they need to have the resources to do that, but I think they need the autonomy to help develop and to identify areas that they think as a group we can work on. And I think there's the national resources that we can provide the opportunity to have access to. But faculty development, in a lot of ways, is it is a team sport with individual players, and I think that a lot of it needs to be driven by the goals of the individual, and we are just kind of there too. I mean, a lot of times I'm just there to write a check sometimes to make sure that things can be done.
Vice Chair's interest group also was an opportunity for people to discuss and share ideas and collaborate as well.
I think some ideas that came up too in my informal needs assessment of people, was especially for mid-career mentoring. that sometimes that can be a good opportunity for reaching out outside your institution or your department, because you do end up with, you get to a different skill set, right? Of like, you've got the basics down of your niche and some of the other areas, but you need that extra level. And I think you spoke about that, Dr. Lema, about especially for people who didn't feel represented in the department, that there might be opportunities outside the department as well to find that group. But I think that that's a great opportunity to be here. I'm going to make sure that we stay close to on time. The case study is actually my own case study, because I put together the slides. What we did at LA County USC, now LA County, I'm sorry, not LA County, LA General Medical Center. We actually restarted a process a couple years ago. In the midst of COVID, a lot of our faculty development activities that have been in person kind of stopped, and then our longtime faculty development champion took retirement, and so we kind of had to start over. Also in response to an ACGME survey question where people are like, what faculty development? We were like, well, we gotta rebrand this. So Dr. Tyra, who wasn't able to be here today, and I went through a process. We really started with a formal needs assessment, and we also checked what resources do we currently have, and decided that we wanted to have like a regular structure to kind of signpost faculty development, because that's a big thing in clinical education teaching right now, is like signposting the teaching. Like, you get the presentation, you're like, okay, now I'm going to teach you, which is exactly what you did before. You just didn't say, I'm going to teach you. So we wanted to signpost our faculty development activities. So we did a needs assessment with a survey that went out to the faculty at large, but then also some small group interviews and individual interviews with faculty members from different divisions, asking what areas are currently excellent and what areas do we need to grow. And we also met with department leadership to talk about that. And what came out of that is that we actually had a lot of internal expertise within our department, but it wasn't necessarily recognized across the department that we had these experts there, right? Because we all know each other clinically. And almost exclusively 95% of our faculty are clinical faculty, and also research or admin or ultrasound or whatever else they are. But we didn't do a lot of talking about our development activities. We talked about our clinical work. And that there were a lot of institutional programs that we were underutilizing, we weren't bringing into our department. And then also there's just a lot of different resources available through different national organizations that we could be partnering with, or we could be viewing together as a group, or we could be attending a conference together. When we got started, one of the big things we did was to notify and publish the schedule ahead of time, and to work with our scheduler. So we wanted to have time. We have our faculty meeting time where we synced with that, because that was already protected. But if we wanted to have a larger event for our faculty, we had to plan 6 months in advance. And those kind of decisions had to be made farther in advance than I think we initially anticipated when we first took this role on. And then we also wanted to mix internal resources with external resources. One, to highlight our faculty members that were doing amazing things and to build those connections, but also to help our faculty think about reaching outside the department as they were developing their own individual goals. And this was for more of the broad scale everybody activities, but then we also had peer coaching groups organized on faculty goals. So we had all the faculty members interested in peer coaching groups send their 3 goals for the year, and then organize them around similar goals. So some of them had a lot of them had the goal of writing a manuscript. So we actually split them into people who are interested in like a pure clinical research group, and then an operations QI group, so that they could really work on their own skills within those. We had a couple people that were developing fellowships, so we got them all mixed together. We actually had a group that was just interested in national leadership, right? And so that they could work together and set goals on that as part of their process. And then we established a recurring schedule, right? Because we know that frameworks help people move forward. So we had the same framework every 6 months, where we had a master class, which was our internal faculty presenting one of their own areas of excellence, and how they had built that career niche and how to help other people think about taking that role. We had an institution-specific resource session. One was accessing all of the resources available through the library, which is not just books, but all the support services available for both clinical and research faculty. We have an outside speaker once every 6 months. Our peer coaching groups have a dedicated session during that protected faculty development time. And then we do a clinical skills refresher. Every 6 months, we have a session that is focused on one type of clinical skill, but we take the whole morning after a very abbreviated faculty meeting to meet about this. And so we have to really plan those ones far in advance to make sure that everyone has the time off. And then we give everybody a month off, usually December and June, because we're all tired by that point. And I don't have my results slide, but we actually, we went from having, about 30% of people being satisfied with their faculty development to 93% on the core survey. So we had really good success with some of this. And some of this was a fair amount of work, and some of this was just signposting and making sure that people were aware, faculty were aware of the efforts that were going towards their development and calling it what it was. So we've restarted, we've gone 2 years strong, and I'm passing off to some other people in my department now, which is also fun. But I think it's been a great opportunity for me to learn a lot about this and to meet some great people. I wanted to leave some time for people to ask their own questions, especially if you're taking on this role or starting a program about faculty development programs and what you might want to know.
Specifically about signposting, can you just give an example of what you literally mean by that? Are you putting out an email? Are you putting out a Twitter, a tweet? Like, what are you doing to actually draw
We're told to tweet. So mostly it's by email. Faculty still like email, although we do group text sometimes. But we have a line in the faculty meeting now. We have chairs update, we have residency update, operations update, various other things that need to happen in that meeting. And then the last item on every faculty meeting is faculty development session, and then what that is. And so we make sure that every meeting clearly states this is the faculty development session, right? And I think sometimes prior to that, there was a faculty development session, but it wasn't labeled that way. It was labeled, airway equipment update, right? As opposed to faculty development session, innovations in airway equipment, right? And some of it, I hesitate to say that it was only branding, because it's not just branding, it's helping your audience be ready to receive that information and making sure that they're aware that it's focused on developing them. The other thing, we have to get going? 1 minute.
Repeat the question.
Repeat the question. The question was, what do we mean by signposting? And so some of it, signposting, the other thing is like a signpost in real life, they all look the same within a city, right? Like that's part of how you know it's a signpost, and that framework helps you. So being consistent in our messaging and how we structured it. And a lot of it came from education theory, to be honest. These are things that we know for best practices in educating trainees is use the same framework. Don't make them figure it out every time, right? And turns out faculty like that too.
Yeah, it's just really as simple as, because our med student educator always tells me, you need to tell the students that you're watching them do a physical exam. So on the survey, they don't say that no one watched them do a physical exam. So it's just really clearly stating that this is actually the time for faculty development today.
Right.
I have a question, and my name is Nancy Kwan. I'm the Vice Chair of Emergency Medicine at Long Island Jewish. I work with Dr. Gupta, and I just wanted to hear all of your perspectives. I think this is a great conversation regarding faculty development. I think one of the things that, we've encountered a lot is like people looking at protected hours and what does that mean. I think sometimes people don't have understand the concept, and we try to sort of like teach on it and explain it, and I think sometimes the negative aspects are kind of, there's people who consider them as the have-nots versus the haves, and a lot of times people ask the question, how do I get more protected time? And a lot of times I don't feel that's the right question. I feel the right question, or a better question is well, what is your passion? I think that's what leads to protected time. So I wanted to hear how each of you address these conversations, and then for people who use protected time well, that's not an issue, but have you seen where people are not using their protected time appropriately? And I know these are hard questions and conversations, but I would love to hear your perspective.
Whole nother hour.
Yeah,
Nancy.
I think that the challenge around protected time and how I also heard some great conversations about this meeting, and really what we're talking about is time not funded by clinical effort, right? And so we've done our specialty in a way of disservice in academics, especially when we talk in shifts. Because if I tell somebody they work 13 shifts, they're like, yep, that's my job, 13 shifts. And we forget that 13 shifts includes time or hours for academic pursuits. And it is really important, especially in this new generation coming up, to understand that their job is just not the shifts. It is the totality of that time that we work. So we have been working really hard to get away from shifts and change to hours, because it's easy for me to explain to somebody that a full-time, according to my boss, is 2,040 hours a year, which is 40 hours a week. And we only work clinically this amount of time. And we know we've got to recover a certain amount of time, but there is some time built in for academic efforts. And really when we give time that is not funded by clinical revenue, I make an effort to be as transparent. There's a sheet that says absolutely what everyone gets based on roles.
And I think it's a marketing issue, that signposting is all marketing and trying to help our faculty develop what they're doing. Sometimes it's not shown as scholarly or innovative or impactful, and I think it's helpful for us to try to develop that part of it to show the impact and also the visibility of what their work, and then try to advocate for non-clinical time.
So thank you all. This is a really great presentation. Zach Meisel, Vice Chair for Faculty at Penn. So I have two quick questions that are hopefully narrow and quick enough that I can ask two, that relate specifically to this presentation. One of which is about peer coaching and how to navigate the confidentiality issues that are so essential with coaching in general in a peer situation. I don't know if you have any experience or thoughts with that. And then the second question is really about institutional resources, again, something that was really nicely highlighted here. How you might think about one struggle we have is that many of the institutional resources are sort of earmarked for specific groups and creates kind of a have and have not, particularly around sort of research or more academic versus more clinical, but also among certain affinity groups, et cetera. It creates a challenge when you're trying to sell some of these institutional resources to my overall faculty, but some of them are really, frankly, exclusionary or inclusive only of certain types of folks. So I don't know if you have thoughts about that.
Yeah, for when we started this program, we went in with this is optional. People are spending their non-clinical time developing themselves as they see fit, but we wanted this to be as broad as possible, and that's why we had both the large group format and the peer coaching format. And the peer coaching was really emphasis specific, that tended to cluster a little bit by either career level or by area of emphasis, not necessarily like tox and ultrasound definitely ended up together sometimes because they both wanted to work on a paper or they both wanted to work on fellowship skills. The peer coaching was optional. 65%-ish or so of faculty decided to join one. Not everyone did, and it definitely trended towards the more senior faculty not joining a group, and also the people that were kind of part-time, if that makes sense. If they were, less than 0.75 FTE, they really didn't put their efforts into that. And we just set the guidelines. We haven't had any complaints or issues of people saying, things weren't kept confidential. And we're not that large of a faculty. We're under 50 for our one main site, and so we all know what everyone's up to anyway. But I think the other thing that we really emphasized was I want to say personal responsibility, personal initiative, that this was about developing yourself, and that in aggregate, we will cover all the bases that need to be covered, but people needed to find the passion that they had. And we kept the large group formats to things that really crossed those overall, everybody needs these skills, and left things like manuscript writing or grant proposals or some of the really technical operation stuff that I am not an expert in, to the peer groups.
I think it's really what you consider peer coaching, right? So when we think about coaching, there can be peer coaching, which is a physician, that formal coaching relationship, which is much different than getting groups together. Mm-hmm. And I do not believe, we have a a physician coaching program at UT Southwestern. The person who's completed that is not going to coach anybody within our department. But we can use those peer coaches to come in and coach groups within our department from outside. So that confidentiality is kind of separate. And I think those are more formal relationships that really confidential.
That's a good point. This is not remedial peer coaching. This was aspirational growth peer coaching, if that makes sense too, because I think that those two terms can be used in different ways to mean different things, and you do have to really clarify at the outset what you mean with that.
Great, thank you.
I would say thank you to my panel. I really appreciate everyone's time and coming in. Thank you.